sometimes taking rest and then going ahead kind of reduces the pain, or sometimes even worsens the pain. So you're taking rest improves, and then I can start walking. Then I take rest for some time, then I start walking. So that is your very, very iconic of arterial claudication. So diabetes and smoking. Smoking is a very, very big risk factor in peripheral arterial disease, and there is intimal damage because of smoking, and because of the nicotine reaction and all that, there's intimal damage, and because of which it is pro if I would say it would be more prone for atherosclerosis. And atherosclerosis, the coating of the blood vessel, internal, the lumen with fat. What happens? The lumen size reduces, right? Heart disease, palpitation, atrial fibrillation, and previous cardiac symptom or ischemic symptom. So these are some essential history which I've thought I'll get it in a table format and I put it up. So you need to know whether a patient had any history of stroke. The thrombus may not have only gone down. There's a possibility of the embolus, would have traveled up also from the heart. So any previous history of stroke, transient ischemic attacks, peripheral arterial disease, diabetes, hypertension, tobacco use, and hyperlipidemia. So you should understand one thing. Sorry. How do I do a physical examination with these patients? How do I say, okay, there is, probably vascular compromise in this patient? So even wherever you're sitting right now, if you look at your lower limb and, the physical examination part of it, you may have, you can have pain, physical examination, any pain in that or tenderness in that area, pulselessness. Do you know, I'm not sure if you know how to check for peripheral pulses. I'm going to explain in the upcoming slides. So this is a different kind of peripheral pulses you need to take. So your dorsalis pedis, if you can touch now and see between the first metatarsal space, okay, first web space in the foot, posterior tibial is medially, popliteal you might find it a little difficult, brachial as you can see, radial upper limb. So for the lower limb, for people who have pain, if your pulses are not very strong enough, your arterial supply is compromised, your pulses will be weak. So you can have either 2 plus normal or diminished or even absent. You may not feel. So in case absent, you need to visit the hospital soon. And pain, pulselessness, paresthesia is numbness, which occurs in about half the patient. Pallor. So because there's a low blood supply, low hemoglobin goes to that place, that area, the foot or wherever, will look pale. Typically one joint above the level of demarcation of pallor. And paralysis, which is a bad sign because the patient has not able to move his lower limb, means the muscles have literally died, the nerves have died in that area because of lack of blood supply, and there is so much of lactic acid and substances that's there. And definitely you can have something known as poikilothermia, inability to regulate the temperature. So the blood supply is good, the limb will be warm. The blood supply is less, the limb, that particular area will be a particular area will be cold. So this is how you check for different arterial pulses. Now, how do I say, okay, this is a classical way of, between doctors, how to determine, okay, how sick is the patient, or, how fast should I intervene? Basically, an arterial blood ankle brachial pressure index. So what happens on your left hand side, you'll see you have a normal artery here and you have a peripheral artery here. Because of peripheral artery, atherosclerosis, fat and all, you see the blood flow is reduced in this artery. So we are suspecting say an arterial disease in this patient. So now come to the right side. So it's a simple test. You need to take blood pressure on both the arms. Your right arm systolic, only systolic blood pressure, left arm systolic pressure. And same way in the lower limb, you need to take the blood pressure, then right ankle systolic and left ankle systolic. Now, how do I calculate the ABPI? Ankle brachial pressure index is basically very, very important. Please note, higher of the right ankle pressure, okay, and then you need to have, among these two, you need to check whichever is the higher arm pressure, okay. And you can have left ABPI is higher left ankle pressure, which are the vessels in interest? You have posterior tibial and you have your dorsalis pedis. So whichever gives you a higher pressure, and you'll use a handheld Doppler to get the signal, just like taking blood pressure. And how do I interpret it? You look at the one on the blue. If it is normal, you'll have a this ratio, higher right ankle by higher arm pressure will give you something known as a zero point 0.9 to 1.3, which is normal, 0.8 mild disease, moderate disease, and severe disease. And definitely, if you have more than 1.3, the vessel is probably calcified. Now, the concept behind it is you're not able to compress a calcified vessel, because of which you have a very high ankle pressure. Okay, but your arm pressure may not be that much. Since your numerator is high, you can even get more than 1.3. So that also is not good. So 1 point up to 1.3, greater than 1.3 is more of calcified. Predictor of outcome. Okay, when you have a patient with this and you quickly take an ABPI, it also predicts the outcome. Index point 7 is critical and you need to act fast. So this is again resting ankle brachial pressure 1 to 1.4.9, less than 0.9, more than 1.4, non-compressible vessel. Now, how do I classify clinical classification of acute limb ischemia? The whole lecture you need to understand as a doctor, as a primary care physician, mission hospital doctors, you need to understand this particular table for acute limb ischemia and when to refer the patient. So, we say the category is viable, threatened. Threatened is again divided to marginally threatened or immediate, and you have irreversible. Something if your patient has come in viable state, not immediately threatened, okay. So you can what happen? Again, sensory loss may not be there, muscle weakness may not be there. When you have a Doppler, handheld Doppler, you may find the signals that are audible. Okay, so that Rutherford classification, category 1 is viable. Okay, now what happens is threatened. Your vascularity is now threatened. You have marginally threatened. So if you act promptly, it's the limb is salvageable. That's what it means. Now, sensory loss may be minimal. However, muscle weakness, patient may still be able to do it, but the sensory, when you touch the patient's sensation might be slightly diminished. So, arterial compromise, arterial sounds may be inaudible, may not feel the pulses or hear the signals. However, venous signals may be present. Immediately threatened means patient needs to undergo in the next 1 or 2 hours. The patient needs to immediately rush into the theater, salvageable with immediate revascularization. So you may have more than the toes that are involved in sensory loss. Now you may begin to see some kind of muscle weakness. Patient may not be able to flex or extend his ankle to toes, and arterial signals are not audible, or venous signals are audible. Irreversible major tissue loss. There's now gangrene that has set in, or permanent nerve damage. Then the entire area is anesthetized. There's sensory loss. There's profound paralysis of that area muscle. You can't hear arterial signals or even venous signals. So this Rutherford classification most commonly used to determine whether limb is viable or threatened or irreversible, and accordingly guide your clinical management. So you have viable, again just revising, we have viable, you have threatened, which you have 2A, 2B, marginally immediate, and you have 3 reversible. So it's always important to examine. The patient may come with one leg, but always very, very important to examine both legs, okay, for bilateral disease. But do not delay your examination. You have quick examination because every time is your tissue, as they say it. Also look for any signs of other areas of ischemia. Is the patient having chest pain, any kind of stroke? Do not concentrate yourself only to the lower limb. Examine patient completely. Okay, any abdominal pain, you may have even mesenteric ischemia. So what happens is patient with neurological impairment or deep venous thrombosis may also have clinical signs and symptoms similar to ALI. So neurological, if a patient may even have a stroke, and you may not, the patient may not have sensations, the patient may not be able to do not confuse it with your acute limb ischemia. Have a clear judgment between neurogenic symptoms as well as your vascular symptoms. So, given the cardiac origin of embolic occlusions, you need to definitely look for a cardiac exam and do an echo, and but without interfering or delaying the treatment. So, the time needed to obtain any kind of imaging should be weighed against the urgency of revascularization. This is the prime, very, very important statement. Whether should I image first or should I plan for a revascularization? Because if it is Rutherford 2B, which I mentioned, Rutherford 2B is just here, you have immediately you need to take the patient to theater. Okay, that's here. So now the thing is whether do I do a non-invasive imaging or an invasive. DSA is a very very good modality, digital subtraction angiography. What happens? The patient, the dye is injected, all the bones, everything gets subtracted from the screen, and you can only see the vasculature, blood, muscles, and all are subtracted. That's a digital subtraction angiography, and only the blood vessels are seen in that particular location, and it's still considered as a standard investigation of acute limb ischemia. It can even delineate etiology, tell you about any traumas or any embolus, and at the same time, there's a benefit of DSA. Whether if an endovascular treatment can be done, a balloon can be put in, or a thrombus can be removed endovascularly. Ultrasound has about sensitivity 88%, specificity of 96%. To detect a stenosis, if it's more than 50%, means the blood vessel is less more than 50% occluded, the ultrasound will pick it up very nicely. Now, what do I need to see in, say, CT angiography? So, CT angiography, what happens is you have an administration of a non-ionic contrast, obtain sufficient opacification of the arteries. Like so, you take from the diaphragm to the toes. So you don't want a venous component to it. So it just there's a timing. As soon as the contrast is given, the machine has a timing. Soon as there's a tracer that's kept, as soon as it hits the tracer, the CT scan starts, and along with the blood flow, you have a CT scan that's running and getting the imaging. So the benefit of CT angiography, it evaluates the thoracic and even the abdominal aorta for any narrowing or any thrombus or anything that we can suspect. Any embolic source, any mesenteric vessels can also be seen. Any extravascular findings. So sometimes when you do a CT angiography, you may even find a mass sitting there, near the IVC, or in abdominal masses, ovarian masses. Maybe malignant, which is, as we know, that cancer or malignancy is a prothrombotic state. The blood clots more in patients of cancer, or or patients having more of clots and things like that. So patient who has a malignancy, underlying malignancy, that becomes a prothrombotic state. So contrast enhanced magnetic MRI, it's not for acute limb ischemia per se, but however this itself is a very very a statement that is there, because MRI takes a lot of time. Patient may lose that window period where you can intervene. However, sometimes these patients are CKD patients, kidney patients. You may not be able to push the contrast. So what happens in those patients? Not for acute limb ischemia, you have a limb compromise, you can even plan for that. So what is the something known as the MR angiogram? So non-ionizing radiation can load angiography is there, less contrast, and it can be alternative for contrast-induced nephropathy patients. So, however, what are the disadvantages? Of course, cost is definitely a deciding factor. And you have a large number of artifacts, sometimes definitely more time consuming than CT, and you may lose that window period to intervene. So what are the lab markers of ischemia? What blood test should I do, doctor, so that I can say that the patient has acute limb ischemia? No, no, no. That may not be a right terminology to use. I would say these are adjuncts to your ischemia. Don't say, okay, this is positive, so patient has ischemia. No. To assess the patient clinically, take a detailed history and examination. Do a good, thorough examination. So basically, you're looking at some byproducts that are formed, and whether your intervention will really help the patient or not. So you have myoglobin and something else creatine kinase. So when there's muscle breakdown, there's myoglobinuria, that is myoglobin breakdown, creatine kinase is there. Rhabdomyolysis, you will know whether muscle breakdown. So you know, yes, indirect marker that there is a muscle ischemia somewhere and the muscle is breaking down. And myoglobin known to precipitate in the renal tubules, cause something kind of an acute kidney injury, AKI. So, creatine kinase is widely used as a marker of ischemia reperfusion injury. It might assist in perioperative management and estimating the risk of major amputation or limb preservation. So, what happens is when you are, you have done bypass, you've done all that. Not everything is rosy. Sometimes doing a bypass itself may be more harmful than doing anything else. So, what happens is when you have there was initially a blockage of all the toxic substances because there was a clot. Now I have done a surgical bypass and made a new channel through which the blood will flow. So what happens is all the toxins that were harboring and blocked because of the vessel blockage now has a new channel to go into the systemic circulation and circulate in the entire body. So that itself is called the ischemia reperfusion injury. I have made a new channel, a bypass, and because of that, there is an injury to the kidney, or the toxins have now circulated. The patient may have a sudden drop in BP. So how do I manage these patients of acute limb ischemia? So whenever the dictum is, whenever you're suspecting clinically, taking a quick history, done an examination, you're suspecting acute limb ischemia, don't waste time. Push 70 to 100 international units per kg up to about say 5,000 international units IV, and then follow it by infusion. Okay, infusion of heparin. So initial bolus dose of heparin will help. If there's any some new clot and thing, it will just till you push the patient to the OT or something needed. You can at least reduce the morbidity and mortality. So once you put the patient on infusion, you need to maintain the APTT between 60 to 80 range. Now sometimes I've seen in my wards also sometimes what happens is patients are given blood test PT-INR and APTT both. So if the patient is only on heparin, you don't need to send a PT-INR other than a baseline PT-INR, because these tests are kind of expensive and you need to do it every 6 hours. Becomes all the more expensive. So you need to, for that's why if the patient is on heparin only, you need to check only APTT level, maintain with 60 to 80. Patient is on warfarin, maintain between 2 to 3, and then you need to check only PTINR. No need to check APTTs. You have inflammation that is there in the blood vessel because there's so much toxins that are were blocked because of a blockage in the vessel. They couldn't move out, and our whole aim is your heparin and all being given is to have an anti-inflammation, have an anti-inflammatory effect, avoid further formation of clots. So sometimes patients may be allergic to heparin, or because of heparin sometimes the patient may develop a low platelets. So what do I do? So in those cases you can even use fondaparinux, lepidolin, argatroban, danaparodine, that may be as a non-heparin use anticoagulants may be used. Now, this is a slide which is like a take-home slide. And now I would say, if you look at acute limb ischemia, immediately, as I mentioned, you give off intravenous heparin injection. And then anyways, you're assessing class 1, class 2A, class 2B, class 3. So 1 and 2, you still have some time for imaging. But however, class 2B is immediate type. So that's why you see a dot, 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 whether you really need imaging or not is the question. And class 3, of course, is irreversible. So when you have an image test that's there, you have done revascularization. You can, once the image test done, you can do revascularization after the image test, or even 2B can be directly pushed into revascularization. What is that revascularization? I'm going to come in the upcoming slide. So then after that, you can have an intraoperative angio, something like a DSA, something additional treatment needs to be done, some clot needs to be removed. Okay, so that is your revascularization part. And of course, you need to give medications to keep the blood thinner, avoid further plans on, avoid further problems on clotting. So class 3 irreversible type you have diagnosed, and another doctor also says don't take these isolated decisions of limb loss. Get another doctor to also certify yes. Ideally, it's not mandatory. You can still do it, but this is for your safety. And the patient may say always say that my limb was good. Or if you have two doctors literally confirming, this cannot be. Yeah, so in our hospital, our general surgery patient comes again, we send to vascular surgery and ask whether it is, limb is salvageable or not. Once they say, okay, may not be it can be given a trial or non-salvageable at all. So then amputation is the choice because you don't want the toxins to build up in your body and then become systemic. So the toxins are only right now in their leg, but what happens is when you reperfuse or you don't do anything, that can become systemic. As I mentioned, your urgency of treatment will depend on the severity of the limb ischemia. So, if you have Rutherford 1, you can either treat conservatively by the medical treatment and even some supervised walking therapy. So, walking therapy will actually improve your collateral supply. And if there's a neurological deficit in the limb, particularly involving motor loss, your Rutherford 2B urgent revascularization is mandatory. So, our one principle is revascularization with least risk to the patient. What are the various techniques that you have? You have surgical thromboembolectomy. You have, where you put in open, you put in a Fogarty catheter, you take the clot out, or you can bypass. If there's a clot, don't do anything to the clot, but proximal to the flow and distal to the clot, you make a bypass. When the highway is blocked, you tend to take the bypass and then meet at the highway much ahead. So like that. So percutaneous catheter directed thrombolysis CDT. So there are special catheters that are there which go into the blood vessel, and you can give anti-coagulation, all that. You can give drugs to dissolve the clot in the vessel itself. It's a very very high end technique thing, but nowadays it's become more common. Put in the through into the blood vessel, either endovascularly or otherwise, and over time what happens is the blood, because it's in constant contact with your embolizing agents, so that will happen, it will dissolve. So, and the other way of thrombus aspiration, mechanical thrombectomy with or without even thrombolysis, removing the thrombus per se. So hybrid procedures definitely include your thromboembectomy. The strategy employed will be depending on the number of factors, including the expertise. You need to know what are the facilities of the treating team, and of course the location and the cause of occlusion, whether thrombus or embolus, and patient factors and the duration, mainly the duration. If the patient says, "No, I just had started having pains in the last 1 hour or 2 hours," immediately rush in and see what can be best done. And severity of the acute limb ischemia. Location and the cause of occlusion I've already mentioned, and then you have comorbidities which can worsen, like diabetes, microangiopathies, and all that, and therapy related risk. Open vascularization technique. So this is your open bypass. As you mentioned, there's a blood is very slow, so you take a bypass from proximal, go all around, and then you anastomosis here. So that is your open revascularization technique. Something known as a balloon Fogarty. You have made the opening here and you've gone beyond the lesion, inflated the balloon, and then try to pull it out. So it will not come. Yeah. So this is what you do. You put in and then you pull out. So if it still not come, you may have to do a repeat procedure. Even have to open up and remove the clot mechanically. So this is a procedure called thromboembolectomy, which is here. That's ABC mentioned here. So it's a balloon that a person named Fogarty had, made this. So femoral incision and up to unilateral iliac femoral profunda clots can be removed. But however, what happens is, this is just a summary of the whole thing, the thromboembolectomy. So what happens is, sometimes when you're removing the clot, I'm trying to summarize this. Sometimes when you're removing the clot may break and go into the neighboring vessel. So you may have started off with one problem, but since you have in the neighboring vessels, you may have to even do an embolectomy there. So if the occlusion is below the popliteal or is in the popliteal artery below, so what happened? From groin entering through the groin, the wires entering through the groin may not be really feasible. You may have to go retrograde from the leg. Direct exploration of below knee popliteal artery should be considered. So yeah, TPL. This is again explaining about the thromboembectomy. So transverse arteriotomy is done, and then this Fogarty is inserted. So what is surgical bypass? So as I mentioned, as in the image, this is your surgical bypass. There's a blood flow is reduced here, so you've made from a good flowing inflow to an outflow, inflow to outflow. So you have anastomosis here, and this is blood may flow whatever can flow, but your new channel will take most of the vascular supply. The embolectomy is usually done in most of the cases. There's a thrombus or embolus. And after doing an embolectomy, you may have to even do a completion imaging to see if there's complete removal or even clot. The patient may improve clinically. You may can always reconsider whether to do a completion imaging or not. So if there is a remaining, say, clots not completed, so you can address that with thrombolytic agents. So acutely occluded bypass grafts. So these bypass grafts can be your veins actually taken from the leg, or you can have synthetic grafts that are there. So if the occluded graft is vein or both proximal and distal anatomy usually require a surgical exploration. Such cases over the wire embolectomy catheters can be useful to deal with this valve cusp issues. So what happens is, sometimes you have within 30 days of insertion of the graft, you have an early graft occlusion. That may be because of, patient not taken care, technical issues, outflow anastomosis, inadequate inflow or outflow anastomotic stenosis can also be there, torsion, some valve defects and clamp related. What happens late graft thrombus more than 30 days? Progression of atherosclerosis over time and hyperplasia in the graft or aneurysmal dilatation. So what happens? CDT, catheter-directed thrombolysis, if you remember, is also an effective treatment for the acutely occluded bypasses. Now there's something known as hybrid treatment. We are almost coming to the closure of a lecture series. So what happens is hybrid treatment. You after incomplete thromboembolectomy, endovascular techniques may be used. So basically, open and a part of it is endovascular. So complete annular release underlying chronic stenosis, balloon angioplasty may be done. So you have endovascular techniques and you have even open techniques, and when combined together, you can form hybrid treatment. What happens in thrombolysis? You can either have a systemic thrombolysis, means that through the vein it's given, and entire blood vessels in the body, but may not have a direct role in acute limb ischemia. However, catheter direct thrombolysis is basically going into the vessel that is blocked, and what happens is any graft infection duration um, that you have after infections in duration more than 14 days, any contraindication to the thrombolysis and failure to position the catheter. So when you're doing it endovascularly, you need to position the catheter near the clot. And position the catheter across the thrombus should not undo. So if patients are not able to, you cannot put the catheter, then also the patient may not be able to undergo the procedure. So contraindications of thrombolytic treatment is a very, very common question that people have. So if you have a cardiac, so your cerebrovascular CVS problem in the last 2 months, then absolute contraindication, active bleeding diastasis, any recent GI bleed, any neurosurgery, patient in the last 3 months, intracranial trauma within the last 3 months. So they are advised to visit the doctor immediately. See, so these are absolute contraindications of thrombolytic treatment. But what happens is relatively major, may or may not, depends on the doctor's discretion. If a patient has system CPR within 10 days, avoid. major non-vascular surgery or trauma within the 10 days, uncontrolled high BP, intracranial tumor, recent eye surgeries, any relatively minor issues like liver failure, hepatic failure, or something, a bacterial endocarditis, pregnancy, or diabetic hemorrhage, retinopathy. So these are all relatively minor. Fibrinolytic drugs, you have urokinase and recombinant plasminogen. Most widely used thrombolytic drugs for CDT, catheter-directed thrombolysis. And of course, you need to monitor the fibrinogen levels. Fibrinogen depleted during thrombolysis, and it's measured could be used to predict the bleeding complications and guide the dose for thrombolytic. So, what are the other endovascular techniques that you can have? So you can either aspirate the devices that aspirate the thrombus, endovascular mechanical, sorry, thrombectomy, ultrasound accelerated thrombolysis. If nothing works out and you want to save the patient's life, and you know the wound is quite bad, toxic, and even rise up to the heart, then it's not worth giving it a trial. So the limb, so the index procedure, non-salvageable, class 3 limb, low potential of limb salvage, amputation, mortality, long-term limb salvage, or open surgeries in acute limb ischemia. So this is a table of how many patients were recruited and all. Yeah, Shiv, are you there?
Great, doctor. Hi, Dr. Vijay.
Hi, Vijay. Long time no
Right.
see.
So, thank you. Thank you, doctor. Thank you so much. Now, doctors, we are opening Q&A session, so please do drop your questions, wherein Dr. Alen will be able to answer your queries. You can type the messages. I will read it for you to the doctor.
Sure. Even our WhatsApp, one of our groups have put up some few questions. Once I've finished their questions, maybe I can proceed.
Please, doctor. You can. First, you will take the questions on the WhatsApp.
Yeah. No,
Then we
first
will
we'll take
come
from
to.
the group, and then see because they're live here attending. So I think we should
Okay.
respect that.
Cool. So, doctors, thank you for attending the webinar. I know there was a small last moment technical issue which from what happened from our end. Inconvenience regretted. Really sorry for that, and we'll make sure will never repeat it again. Now, please drop your questions on the message center. We'll get the answers from the doctor.
Even if they want to, ask, we can unmute, they can unmute and ask.
I have, yeah, they can now. I have given the permission, they've made the settings. Now doctors can mute themselves and ask the questions. Doctor, I think there are no questions.
No problem. I'll proceed to the
Yeah.
questions sent to me on WhatsApp.
Please, please, doctor, please.
Just one second.
Please.
Yeah. So the first question says, Doctor, what is the most common cause of acute limb ischemia? Well, Dr. Shaji, I would say that most common cause of acute limb ischemia could be embolism, and embolism mainly coming from the heart. So atrial fibrillation is there, and the heart has thrown off an embolus, and has gone there. And even one more thing, if you are already compromised limb on the narrow lumen lower limb is there, if a heart clot goes and plugs it, it becomes an acute limb ischemia. So I hope I've answered your question, Raji. Yeah, the next question has been brought by Sunita. So she says, what is the first line treatment for acute limb ischemia? So the first line treatment, I would say, would be immediately if you're suspecting, give off 5,000 units of heparin if it's an adult, and followed by some thrombolysis or embolectomy or even surgical revascularization based on the severity of the. Okay, and then the next question he has asked, Rahul. Could you throw some light on ischemia reperfusion injury? Sure. Rahul, so this ischemia reperfusion injury, you should understand that blood flow is less, but the function is more of that limb. So what happens is there is lactic acid, collection, and you have, the increased amount of, P substances and all that. So that is all there. But when a bypass is created or the channel becomes canalized or the blood supply is improved to that particular area, so as a detrimental effect, what happens is all those toxins start circulating in the entire body, and then you can have problems there, and you can have a low BP, sepsis, and other issues that can be there. Johnny has asked another question. What are the other things to note in acute limb ischemia in or with respect to the systems involved? Okay, so if all would have heard of cardiac disease, heart attacks, everything. So heart attack, what happens when the vessel in the heart gets narrowed or there's a blood clot there, there is compromise to that particular area. So what happens if there is a blood flow that is reduced, okay, to that area in the limb, it's like a heart attack or attack to the lower limb vasculature. You can consider it that way. So similarly, the other systems you need to look at is you need to look at the cardiac system, the lungs, and even the brain. You need to rule out any evidence of stroke. You should not miss a stroke and call it an acute limb ischemia. Of course, they may or may not coexist, but in window period of stroke, you need to really, look forward.
Great. Doctor, we have a question. Dr. Gautam is asking, sir, why should we go with amputation? We can go with angioplasty or thermo
Thromboembolectomy,
thermoembolectomy.
amputation is
Amputation
really
is
needed
really
or
needed.
not?
Sorry.
So you need to understand, Dr. Gautami, once the patient has presented very, very late to you, okay, and the leg is foul smelling, is gangrenous, and that has become a septic focus. So it is advisable to remove that particular part of the limb so that the infection does not become generalized and cause severe sepsis, and a patient goes into shock and can be life threatening just because of the limb. So as a dictum, they say save life first, okay, limb after that. Okay, so if your life is secure, then you can you need to save the limb. So you are right, if the patient presents beforehand, as I said, six within, if it's an acute limb ischemia presenting within 6 hours, then you can definitely look for endovascular techniques and thromboembolectomy and all that, but you may even have to definitely consider amputation if there is gangrene in that particular area. And another thing is you may remove that particular limb, and also you may have to revascularize that particular area. Why? Because what happens once you have amputated, there is something known as a stump. the amputate stump that is there. The leg is removed below the knee or whatever. What happens? There's a stump. The stump is actually a raw area. Okay, that may not heal if you don't improve the vascularity to that. So the patient will definitely require some intervention to improve the blood supply to that area to heal the area that is now under study. Yeah, I hope I answered Gautami's question.
Thank you, doctor. Doctor, I think we will. Okay, Adil Khan. Yeah, doctor, we will end the meeting then. I guess there are
Sure.
no more questions. So thank you for all joining us today. We hope you have found this webinar informative. If you have any further questions, would like more information, please feel free to reach out to us. Additionally, we will be dropping a link in the chat box for you to fill out the certificate form. Please do fill out, and you will get a certificate by tomorrow end of the day. And additionally, thank you. Also, don't forget to follow us on social media. And thank you, Dr. Alen. Thank you so much for joining us today and enlightening with a lot of medical information. And I, behalf of all the candidates, I would extend the warm regards to you. Um, I guess, yeah. We'll be here for 2 more minutes. Please do use the link from the chat box to fill the application form so that you'll get the webinar participation certificate. Thank you so much, doctor.